welcome back to another explainer. Right now, as you're listening to this, your heart is beating with enough mechanical force to shoot blood literally several feet into the air. It's an absolutely incredible, tireless engine. But today, well, we're looking at what happens when things go wrong. We're going to examine one of the most dramatic and frankly terrifying events that can occur when that high-pressure cardiovascular system just completely fails, an aortic dissection. So let's dive right in. Picture the main water line coming out of a massive city pumping station. Now imagine that industrial pipe doesn't just, burst outward into the street. Instead, it actually starts peeling apart from the inside out, trapping all that high-pressure fluid within its own structural walls. That is exactly what happens in the catastrophic, ticking clock medical emergency that we call an aortic dissection. Here is our roadmap for today's explainer. 1. Anatomy of a tear. 2. Causes and risk factors. 3. Types and complications. 4. Spotting the danger. And finally, 5. Emergency treatment. Let's get to it. Starting off with Section 1, Anatomy of a tear. Okay, so our blood vessels aren't just simple rubber tubes. They're constructed of distinct, specialized layers. A dissection kicks off when a specific part of the vessel wall, the tunica intima, which is that innermost endothelial layer, is literally ripped open. Normally, this layer is incredibly smooth, right? It lets blood just glide by completely friction-free. But when it tears, it's kind of like the interior wallpaper of a high-pressure pipe suddenly catching an edge and violently peeling away from the foundation. And once that initial tear happens, a pretty brutal mechanical cascade begins. The blood flowing through the aorta is under immense pressure, and it violently wedges itself right into that microscopic opening. That high-pressure blood basically acts like a crowbar, physically shearing the delicate tunica intima right off the thicker muscular middle layer, the tunica media. As the blood tunnels between these two layers, it pulls there, and it aggressively expands the outside diameter of the whole blood vessel. The result of all that high-pressure tunneling is something medical pros call a false lumen. It's essentially a rogue, parallel pocket of trapped blood that's expanding alongside the true lumen, which of course is the regular, intended pathway for your circulation. And as this rogue tunnel grows, stealing blood, taking up physical space inside the chest, it becomes the source of all the life-threatening danger we're about to look at. Moving on to Section 2, Causes and Risk Factors. For dissection to actually happen, you usually need a pretty specific, dangerous recipe. You need an underlying weakness in the vessel wall paired with extreme internal pressure. Chronic hypertension is a massive culprit here, whether that's from high stress or even the naturally increased blood volume that happens during pregnancy. But there are also structural weaknesses that set the stage. A physical narrowing of the vessel called coarctation creates a really dangerous pressure bottleneck. Then you have connective tissue disorders, things like Marfan's or Ehlers-Danlos syndrome, which fundamentally weaken the collagen holding the vessel together. Even pre-existing bulges, aneurysms, can act as a weak point, just ready to fail and initiate this whole peeling process. Now, you might be asking, why does this usually happen in the aorta specifically? Well, it's all about location, location, location. The aorta takes the direct, unadulterated blast of blood straight from the heart's massive left ventricle. We're talking about a vessel that handles nearly 2,000 gallons of blood every single day. I mean, that is a staggering amount of fluid. That constant, relentless, pounding mechanical force with every single heartbeat makes the aorta the absolute prime target for this exact type of shear stress failure. Let's jump to Section 3, Types and Complications. To map out the chaos, doctors use the Stanford Classification system. And again, it really just comes down to anatomy and location. Type A dissections are absolutely the most critical. These happen in the first 10 centimeters of the upper aorta, right as it exits the heart, so they're bearing the absolute maximum pressure the body can generate. Type B dissections involve tears farther downstream in the lower or descending aorta. But here's the truly terrifying part. Both types can tear so violently that the false lumen extends all the way down the entire length of the core and right into the patient's abdomen. As that false lumen grows, the fallout is rapid, and it really depends on where the trapped blood forces its way out. It can flow backward and actually fill the sac around the heart, crushing it from the outside, a deadly situation called pericardial tamponade. It could also burst completely outward through the vessel's final layers, basically draining the body's vascular system into the chest cavity in mere moments. Or, the expanding false lumen simply bulges inward so much that it acts like a kink in a garden hose, choking off branching arteries and immediately shutting down blood supply to vital organs like the kidneys or the arms. Section 4. Spotting the danger. So what does a tearing aorta actually feel like? Well, patients almost always describe this incredibly sudden, sharp, literally tearing chest pain that violently radiates straight through to their upper back. But doctors are also urgently hunting for physical signs that the plumbing is compromised. Because that false lumen might be pinching off major arteries, a massive red flag is a weak pulse downstream, like in the leg or arm. A doctor might even take the patient's blood pressure in both arms simultaneously and find radically different numbers. That is a surefire sign that blood flow is being hijacked on one side of the body. To confirm this and actually see those torn layers, doctors have to move incredibly fast with imaging. Time is literally tissue here. A standard chest X-ray might show an ominously widened aorta shadow, but for a high-def view, they rely on advanced tech. They might use a TEE, a transesophageal echocardiogram. This involves safely dropping an ultrasound probe right down the esophagus, sneaking the camera directly behind the heart, totally bypassing the ribs for a clear, unobstructed picture. Or they'll use CT or magnetic resonance angiography to generate a flawless 3D map of the failing vessel in real time. Looking at all these intense, high-speed diagnostics, you might be wondering, just how fast can the situation actually deteriorate if it's left unchecked? Why do emergency room doctors treat an aortic dissection with the absolute highest level of urgency? Well, the answer is pretty brutal and simple. You only have so much blood. If the outer wall of the aorta completely ruptures, blood violently leaves the closed loop of the vascular system. This triggers a catastrophic drop in blood pressure, known as hypotension. And this rapid, massive blood loss sends the patient's organs into immediate shock, which is very often fatal before a surgical team can even scrub in. It's a true race against the clock. And that brings us to Section 5, Emergency Treatments.
So the treatment pathway here depends entirely on that Stanford classification we discussed earlier. Type A tears, the ones critically close to the heart, demand an immediate open-chest surgical strike. A surgeon literally removes the torn, dissected section of the aorta, sews off the false lumen, and physically rebuilds the pipe using a synthetic graft, sometimes reinforcing the whole thing with a wire mesh stent. Type B tears, located further down, well, they're often managed a bit differently. Instead of rushing to open the chest, doctors will often aggressively deploy IV medications like beta blockers and nitroprusside. This drastically forces the patient's blood pressure down, removing the mechanical stress and hopefully stopping the tear right in its tracks.
It is genuinely incredible that modern medical engineering can actually rebuild or medically manage the body's main high-pressure pipeline during an active failure. But the real takeaway here as we wrap up this explainer is all about prevention. Knowing that chronic hypertension is the primary wedge driving this catastrophic failure, are you managing your own blood pressure before the vessel gives out? It's a vital, potentially life-saving question to ask yourself. Thanks so much for exploring the dramatic mechanics of aortic dissection with me, and I'll catch you in the next explainer.